I've been in the surgical field long enough to recognize the rhythm of the operating room. You prepare, you pause, you listen. Every sponge is accounted for, every clamp tracked, and every scalpel blade registered with the precision that only those of us who thrive under pressure learn to appreciate. This team was seasoned. Dr. Mitchell was the lead surgeon. Our circulator that week was Hannah, a veteran nurse with keen eyes. I was the scrub nurse on a hernia repair scheduled for the mid-afternoon shift. Typically, this kind of case feels routine but still demands the same respect as an emergency surgery. We had set up the Mayo stand. All the instruments were laid out perfectly: scissors, clamps, needle drivers, retractors, and the scalpel handle fitted with a number 15 blade. We double-checked, and our count was accurate. It began subtly. I reached for the Metzenbaum scissors, which I had placed to the left of the scalpel. They were gone. I paused, thinking I might have bumped into them or that Hannah had moved them without notifying me. Upon asking her, she replied, "No," while glancing at the count board. "I haven't touched your area." I checked the back table, finding nothing. The floor was clear, and I even looked under the sterile drape, but there was no sign of them. Eventually, those scissors reappeared under the foot of the gurney, nestled between the frame and the wall, clean and unused, but out of the sterile field. Initially, we attributed it to fatigue. Long hours and back-to-back procedures make it easy to misplace things, but the issue persisted. A week later, during a laparotomy, the Richardson retractor disappeared while we were positioning it. I had placed it just next to the Babcock clamp, but it was missing when I reached for it again. The surgeon joked, "Are you hiding tools now?" We rummaged through the area during our closing count and eventually found it resting under the anesthesia cart. No one had walked there, and the field remained untouched. This shouldn't have happened. Over the subsequent month, it became a pattern. Always one item, always clean, always returned. Not by someone's hand, but by the passage of time. Sometimes it happened mid-procedure, sometimes during the post-op cleanup. We began documenting these occurrences, not for ghost stories, but because even a single missing instrument is a serious matter in the OR, with significant legal and ethical implications. We reviewed the surveillance footage but found nothing suspicious, just empty frames where instruments should have been, then frames where they suddenly reappeared elsewhere. I started to double-check every inch of my setup, positioning each tool thoughtfully and keeping the count sheet close. My stethoscope hung on the hook next to the Pyxis machine. Yet, the strange occurrences persisted, happening maybe once or twice a week. One night, after a particularly intricate bowel resection, I stayed back to help clean up. I was winding down the tubing and removing my gloves when Hannah walked in with a grin. "Looking for this?" she asked, holding up a Kelly clamp, which she had found under the legs of the operating table. We both paused. That was the third time that week. She sat beside me on the stool and said something that resonated with me. "You know, maybe it's not about ghosts. Maybe it's just the room trying to breathe. These walls carry so much pressure, grief, hope, and fear. It has to go somewhere. I'm not sure what to believe. What I do know is this: I've never lost a patient due to a missing tool. I've never failed a count or breached protocol. But I've come to accept that sometimes things move in ways we cannot explain. Tools disappear and reappear, perhaps due to distraction, a trick of the mind in an overworked body, or maybe the room remembers all who have passed through it. And sometimes it shifts just enough to remind you that you're not entirely in control." I was in the on-call room, barely catching my breath between cases. It had already been a long night: 2 intubations, a massive gastrointestinal bleed, and a motorcycle accident. When the pager buzzed, I didn't even flinch. After 19 years in emergency and trauma nursing, you learn to move quickly. We received a level 1 alert for a male patient, 37 years old, with a perforated bowel, suspected internal bleeding, unstable vitals, and a root. O2 was being prepared when I arrived. I washed my hands, tightened my hair, adjusted my goggles, and entered the room. The anesthesiologist was already downstairs, and Dr. Thompson, our trauma surgeon, had just completed a ruptured appendix. The techs rolled in the crash cart and surgical trays while I began the standard inventory. I checked the electrocautery unit, power settings, grounding pad, and suction levels. I adjusted the surgical light arms, checked for patency, and resecured the 20-gauge line with extra tape. No time to lose a line mid-surgery. I prepped the Foley catheter kit and got 4 units of O-negative blood ready just in case. The patient arrived semi-conscious with blood pressure barely stable. EMS had already inserted a 16-gauge line in his left antecubital area, with fluids running wide open. We moved quickly. I transferred leads, set up the pulse oximeter, and adjusted the monitor to split screen for ECG and MAP. He looked pale and diaphoretic. Peritonitis was evident, with a rigid abdomen, shallow breathing, and eyes darting around, trying to stay awake. "Count to 3, the anesthesiologist instructed. Propofol was administered. I added a small dose of fentanyl. Once he was out, I inserted the Foley catheter, draped the field, adjusted the retractors, and double-checked the sterility of the bow tip. We prepped the abdomen with betadine, cleaned from the inside out, and gathered the necessary supplies. That's when I noticed something unusual. It wasn't dramatic. No flickering or shapes above the lights, just a subtle movement. My gaze shifted to the foot of the table. There, at the edge of the sterile field where the monitor cables hung over the pole, stood a figure in a white coat, with older gray hair and arms folded. I didn't speak or react, not out of bravery but to maintain sterile focus. Dr. Thompson was making the midline incision, carefully through the fascia, while I clamped a bleeder and positioned the suction tip. The figure remained still, just watching. I felt a familiar gaze locked on me, and then I heard a voice in my mind. Not aloud, but clear and instructive. "Check the bowel loops. He's bleeding posteriorly fast." I've participated in countless surgeries and knew what to expect, but there was something about that message, the urgency with which it pressed into me. It wasn't my voice or instinct. Taking a chance, I quietly said, "Doctor, could we reposition the retractors posteriorly? There might be deeper bleeding." Dr. Thompson didn't hesitate. He trusted me completely, as always. He nodded and adjusted, leading us to discover a small but rapidly tearing mesenteric artery bleed on the posterior side. He clamped it just in time. Another minute and that man would have gone into cardiac arrest. The surgery went on. We irrigated, checked viability, placed drains, sutured, and documented everything. I was back in my rhythm. By the time we rolled the patient to recovery, his blood pressure had stabilized. He was going to make it. I returned to the operating room to clean up, wiping down the Mayo stand, disposing of sharps, and logging instruments on the count sheet. That's when I spotted it again. A photograph taped to the side of the cabinet, half hidden behind old printouts and QR codes for supply ordering. It was Dr. Samuel Reed, our former trauma chief, who had died in that same or from a cardiac arrest 5 years prior while assisting in a case. A sudden aneurysm, they had said. I'd never worked directly with him, just heard stories. Respected, sharp, methodical. He demanded perfection but trained like a mentor. I had seen that face once or twice on the memorial plaque near the elevators. I wasn't imagining it. I wasn't making it up. I didn't feel cold. I didn't tremble. I didn't shed a tear. I simply stood there, gazed at his picture, and uttered, "Thank you." Then I clocked out. Another life preserved. Not solely through science, not just by our training, but perhaps, simply perhaps, by someone who still valued the work long after their shift had concluded. We had just completed the second procedure of the evening, a routine laparoscopic cholecystectomy. The patient was an elderly woman named Mrs. Clara Simmons, 82, a widow with hypertension and no known drug allergies. Surprisingly, her lab results were stable for someone her age. The preoperative team had prepared her meticulously. For access was achieved on the dorsal side of her left hand using a 20-gauge catheter, and fluids were running, specifically lactated ringers. Her consent had been obtained earlier that morning. I can still hear her gentle, slightly raspy voice as she was wheeled in. "My husband always told me not to be afraid of doctors," she chuckled softly. I smiled behind my mask and squeezed her hand. After nearly 27 years in this field, I've always prioritized being human first. Skills and machines don't matter if you forget the person lying on the table. We followed every procedure carefully. Her airway was managed without issues, intubating her with a cuffed 7.0 ET tube and optimizing the ventilator settings. General anesthesia was maintained with sevoflurane and propofol. Her vitals were monitored continuously on Philips and Teleview screens. The sterile field was set up, and the surgeon, Dr. Stephen Grayson, was someone I trusted completely. Steady hands, no ego. However, around the 45-minute mark, her heart rate began to decline gradually. It wasn't sudden. It crept in slowly. Bradycardia followed by a drop in blood pressure. I immediately checked the 4-line for patency, and it was intact. Anesthesia was already adjusting medications. Atropine, fluids wide open. The crash cart was brought in as we began the ACLS protocol, performing chest compressions and pushing epinephrine every 3 to 5 minutes. Her O2 levels were monitored, remaining low. We worked relentlessly for 35 minutes. Then the silence came. No pulse, no cardiac activity. Time of death was recorded as 1852. I stood still in the quiet room, feeling the unfairness of it all, the way a body loses its fight. Her hand, once warm, was now lifeless. It's never just about death. It's the absence of everything they were. I gently removed the ECG leads, disconnected the 4, and wiped away the gel from her chest where we had placed the defibrillator pads. The pads felt almost disrespectful while still attached, but protocol required their presence until post-mortem documentation was finalized. We cleaned her up with warm saline wipes and draped a fresh, white sheet over her. It was the least we could do to honor her dignity. Later that night, around 22:10, I returned to the operating room, having left my stethoscope, my cherished Littmann Classic III. It had been my companion for years. The room was dim, illuminated only by the soft amber glow of the monitor standby lights against the steel surfaces. There was no movement, just the quiet hum of the air filtration system. As I stepped in, I was taken aback to see her by the door. Clara Simmons, wearing the same hospital gown, her hair perfectly curled as when she arrived. Her hands were folded. She wasn't transparent or floating. She stood there like someone waiting for a restroom to become available. She looked at me, not with malice or a creepy grin, but with an expression of peace. Her lips lifted into a familiar, faint smile, the same one from earlier in the day. I found myself frozen. I didn't run or speak or blink for what felt like an eternity. Then she was gone. Not in a dramatic way. She didn't dissolve or vanish into thin air. She just ceased to be there. I held my stethoscope for a long time, and while my heart wasn't racing, I felt a weight in my chest, as if grief had taken a physical hold inside me. Perhaps it was fatigue or my mind trying to process death. But I know what I saw. I recognize her face. I don't often share this experience. It's not fear of judgment. Rather, the weight of this job is already immense. We are expected to heal, to hold people together with tape and tubing and time. Yet sometimes, the most human thing we can do is witness the ending with gentleness and grace. That night taught me something that I carry into every procedure since. Sometimes the body departs before the soul, and occasionally, they return to say thank you. My name is Sarah. I've always said that the operating room teaches you to expect the unexpected, while also helping you remain calm when it happens. With over 20 years of experience in perioperative services, I've witnessed power outages, malfunctioning suction, monitor failures, and even had a patient's tooth break off during intubation once. However, there's one particular moment that stands out, not for its nature but for the way it felt. It was a routine laparoscopic procedure, an appendectomy. The patient was a young man in his mid-20s, healthy with no remarkable preoperative concerns. His vitals were stable, anesthesia went smoothly, and we had just begun the dissection phase. Dr. Jenkins was the surgeon, known for his steady hands and precision, not much for chatting. The room was silent except for the gentle beeping of the monitor and the occasional exchanges between the scrub nurse and the surgeon. That's when the surgical light above us flickered. Now, our lights aren't your typical ceiling bulbs. They're high-intensity, shadowless surgical LEDs mounted on flexible arms, designed to remain stable regardless of how long the procedure lasts. They undergo thorough checks at the beginning of each shift. If anything seems off, our biomed team takes care of it. Everything had been fine that morning after our checks, yet here we were, mid-procedure, and the light flickered again. It wasn't just once, as if from a power surge. It blinked twice, paused, then flickered again. Not complete darkness, but enough to grab everyone's attention. Dr. Jenkins paused for a moment, not out of fear but assessing the risk. "Check the wiring," he instructed calmly, his eyes still focused on the scope. I nodded and took a step back to look at the control panel. Nothing appeared abnormal. The backup power hadn't engaged, and the room lights were fine. It was solely the surgical light that was misbehaving. Then it flickered once more, and I sensed the scrub tech beside me shift uncomfortably. After years in the field, I recognized that look, half rational, half remembering every strange story we've ever heard in the OR. The reality is, hospital staff don't often discuss these eerie moments, but they stick with us. The sudden cold spots, the empty elevator stopping at odd floors, the patient who speaks to invisible figures before induction, and, occasionally, the flickering light. Everyone in the room was silent. Not scared, just unsettled. So, I did what I typically do in situations like this. I reached up and tapped the metal base of the light, mumbling under my breath, "Not today, spirit." The room didn't chuckle. No one does during surgery. But there was a shift, a collective breath released. The scrub nurse shot me a quick smirk. Dr. Jenkins didn't comment, but I noticed his shoulders relax. After that, the flickering ceased, and the rest of the procedure continued smoothly. There were no complications, and the patient was discharged 3 days later, smiling and walking. Yet, we all remembered that moment. I didn't mean to be funny. It was part habit, part instinct. Nurses have countless rituals, both spoken and unspoken. Specific ways we prepare the table, fold the drapes, and words muttered under our breath. Not because we genuinely believe in spirits, but sometimes it feels like the room is listening. I reported the light to Biomed, and they conducted a full inspection the next day. No issues were found, not in the circuitry, wiring, or anything loose or burnt. They replaced the light just to be safe, but the report came back with no findings. I can't explain what caused it. Maybe a voltage irregularity, a brief fluctuation absorbed by the system, or something else entirely. But I do know this: the operating room teaches you humility. It constantly reminds us that despite our precision and training, we remain human, working in a space where life hangs in the balance between steel and breath, knowledge and instinct, and sometimes between the known and the mysterious. On that day, the light flickered, then it didn't, and sometimes that's all the explanation you'll ever receive. It was a calm Tuesday night in the ER when we had a walk-in around 11:45 p.m. A middle-aged woman in her late 40s arrived, clutching her left arm, clearly in pain with swelling at the distal radius. There was no deformity, but her description of a fall down a short flight of stairs suggested a possible fracture. I assisted her onto bed 7 and conducted a quick neurological check. Her capillary refill was normal, and there was no numbness or tingling in her fingers, only the evident pain and swelling. I went to retrieve her chart and order a portable X-ray, taking only about 90 seconds. I distinctly remember the time since I was also checking on another patient. When I returned to the room, I noticed a man standing next to the patient's bed. He appeared to be in street clothes, not scrubs or a visitor badge, and was simply observing her from a couple of feet away. His posture was stiff, almost frozen in thought. Initially, I assumed he must be a relative who slipped in while security was distracted. I quickened my pace to ask who he was, but by the time I reached the curtain, he was gone, without a sound or movement. The patient, still sitting upright, was fixated on the TV. I looked around to see if anyone was still around, but there was no one behind the curtain or in the hallway. Unsure of what had just happened, I asked the patient if someone had come in to check on her. She looked puzzled and said no, she had been alone. I pressed further, describing the man, but she shook her head, insisting no one had entered besides me. I then took her vitals. BP 13886, pulse 92, Oxygen saturation 97% on room air, documenting her pain level as a 6 out of 10. About 15 minutes later, the portable X-ray technician arrived, and as we stepped out of the way, I scanned the hallway one more time, still expecting to see someone who shouldn't be there, but there was nothing. After things settled later that night, I reviewed the security footage from a camera over the nursing station that partially captured room 7. I saw myself leave her bed, but there was no sign of anyone else entering or leaving. I decided not to mention what I had seen to the patient, wanting to avoid causing her unnecessary fear, yet I couldn't shake the image of that man from my mind. He had been completely motionless, his body angled just enough that I never could see his whole face. This wasn't the first odd occurrence in that room. Anyone who has worked in our ER long enough knows Bed 7 has a strange history. A few years back, we lost a middle-aged male patient there due to a heart attack. His wife remained by his side until we called the time of death, standing right where I had seen the man. Maybe it's all just coincidence, or perhaps I was simply fatigued. In this line of work, you learn to avoid jumping to conclusions. We deal with enough real trauma without getting distracted by unexplained phenomena. But I trust my instincts, and that night I know what I saw. We treated the woman's arm, confirmed it was a clean break, and sent her home with a temporary cast and a follow-up appointment. As I escorted her out, she briefly glanced down the hallway toward room 7 and asked casually if the place was old. I told her it was built in the 70s, and when she said she thought she saw something move earlier, she shrugged it off as maybe the effect of pain medication. I smiled and let it go, knowing there's no protocol for dealing with the unexpected sight of someone by a patient who isn't really there. You can't document it or call it in. You just take a breath, stay calm, and do what you've been trained to do. In the ER, sometimes not everything that enters the room leaves again. Some just linger. There's one room in our ER that most staff tend to avoid discussing. It's not for dramatic reasons, but because it defies explanation, which is unsettling in a place defined by facts and procedures. It's designated as Storage 3B, concealed behind utility closets in a back hallway near the trauma area. If you're not paying attention, you might overlook it entirely. It has no signs aside from a faded label on a rusted door. Most new staff don't even notice it until someone mentions, "Don't try to use that one. It stays locked." And it does, or it should. No one possesses a key, not housekeeping, maintenance, or even administration. Years ago, when I was still new, I asked our charge nurse about it, but she merely shook her head. She simply shook her head and said, "That room's been locked since before I started working here. They lost the keys during renovations. There's nothing important in there." And that was the end of it. However, here's the strange part. Every few weeks, sometimes once a month or even on consecutive nights, that door would be unexpectedly found ajar. Just slightly open, not forced, but enough to catch your attention. It became a sort of unspoken routine. A nurse would go for clean linens from the supply cart in the next closet, glance to the left, and there it was open again. Each time we'd call facilities and they would come, check the latch, shake their heads, and secure it with a heavy chain and padlock. Yet the door would open once more. One night, while I was on shift with Angela, one of our most calm and no-nonsense nurses who had been there even longer than I had, we were restocking isolation gowns in the back hallway. It was around 3 a.m., the time when things usually quiet down, and even the fluorescent lights seem weary. I remember Angela suddenly freezing, and I followed her gaze to see that storage room 3B was open again, just a narrow gap between the door frame, as if someone had slipped inside and left it ajar. We approached cautiously, not from fear but from curiosity. We didn't know if someone had broken in or if a patient had wandered in, or if something was amiss. Then we heard it. Not footsteps or voices, but something else entirely. Sounds like boxes moving, paper rustling, and a low scraping noise as if something was being dragged across concrete. Angela glanced at me and said, "You heard that too, right?" I nodded, and we stood there for about 15 seconds, listening. The sounds were sporadic, enough to convince us we weren't imagining things. Then silence fell. We called security. They swept the area, inspected the room with bolt cutters in hand, but found nothing. Just old, unused supply racks gathering dust, no footprints, no signs of life. So they locked it again and added a second lock this time. I remember one guard joking, "Maybe we should just brick it up." We laughed, but there was an undercurrent of unease. Later that week, I was back on the night shift, doing rounds, checking suction in each trauma bay, ensuring the crash carts were sealed and the O2 tanks were above 500 psi. As I passed the hallway, the door was open once again. This time, I felt a distinct change in the air near it. Not a breeze, just a pressure similar to when you open a freezer and cold air rushes out. But there was no vent, no draft, only the open door and that heavy silence as if the room itself was waiting. I didn't go in. Instead, I backed away and informed the attending on call. We went back together, but by then it was closed again. That was 5 years ago, and still, every so often, someone reports it open. It never happens during the day when facilities or administration are present, only during the nights with the nursing staff. One nurse speculated that it was once used for holding patients who passed away before the morgue was relocated. Another said there had been a fire in there decades ago, which melted the storage carts into the floor, but none of this information is documented officially. What is known is this: Storage Room 3B is no longer part of the inventory. It isn't listed on our floor maps, and even our disaster preparation plans omit it. It's simply a room we all agree to leave alone. Some nurses still check it during their rounds, while others avoid it entirely. But every time we pass by, we glance that way just to see if it's open. When it is, we report it as usual and then return to our patients, back to 4 pumps, charting, NG tubes, and Foley care, things we can explain. Yet, every time I hear an unexpected rustle down that hallway when no one should be there, I pause long enough to wonder, what happens in the room that the hospital has forgotten but something else has not? Some patients are unforgettable, not due to the trauma, the procedure, or even the result, but for another reason. Something that won't be documented in the medical records. He arrived at 8:17 p.m., which I recall because I was in the middle of recording vitals for a sepsis case when his name displayed on the board. An elderly man came in, walking, with no apparent injuries. The triage note simply stated he was dying tomorrow. That's not something to ignore, even if it seems odd. I then walked to the waiting area. He was sitting quietly, hands folded, showing no signs of discomfort. Likely in his mid-80s, he was dressed neatly in an old flannel shirt tucked in. His eyes met mine before I could even address him by name. He stood up without waiting for a prompt. "You're the one I was meant to talk to," he said. I brought him into exam room 4 and took his vitals. Blood pressure 12274, pulse 76, oxygen saturation 98% on room air. He had no fever or acute complaints. When I inquired about why he came in, he paused before responding. He said, "I had a dream. I saw myself lying still at exactly 4:44 tomorrow afternoon, and I knew it wasn't just a dream. When I woke up, it settled in me. That's when I'm going to die." I've encountered my share of disoriented patients, those with sundowning, dementia, or psychosis, but he was fully coherent. His eyes were steady, his speech articulate, with no tremor or blank stare. Just certainty and calmness, not panic. He spoke of it as casually as one might discuss the weather. The attending physician that night went along with a complete workup. CBC, CMP, 12-lead ECG, troponins, urinalysis, and a chest x-ray. Everything came back normal, not even mild dehydration. We kept him under observation for a few hours. His heart rhythm was stable, sinus with no PVCs, and oxygen remained in the high 90s. There was no fever, no signs of infection, no neurological deficits. He ate a turkey sandwich and drank a cup of black coffee. At one point, I asked if he wanted us to contact his family. He replied that they wouldn't understand. He just didn't want to be alone when it happened. Still, we had no reason to admit him. He wasn't unstable mentally or physically. Around 1 a.m., after discussing it with the physician again, I gently informed him that we were going to discharge him. He didn't protest, he just nodded and smiled. "You've been very kind. I hope you'll be here tomorrow," he said. He shook my hand, holding on a bit longer than usual, and then he left. The following day, I was not scheduled to work, but when a nurse called out sick, I was asked to cover the shift and agreed without much thought. At 4:31 p.m., I was escorting a patient from room 2 to imaging. As I returned through the ER doors, our clerk signaled me to come over. EMS was en route for a cardiac arrest. An elderly male had collapsed at the bus stop downtown. He arrived at 4:43. I knew, even before they pulled the gurney out of the ambulance, that it was him. He was unresponsive and lacked a pulse. CPR was in progress. We initiated full ACLS protocol, chest compressions, bag mask ventilation, and connected him to the monitor. Flatline, no shock advised. We administered epinephrine and repeated it every 3 minutes, but there was no response. His pupils were fixed and dilated. At 4:44, I glanced at the clock. The second hand moved into place as if it were following something greater than mere time. We officially called it at 4:44. There were no indications of a myocardial infarction, no aneurysm, and no visible trauma. The labs from the night before didn't point to any hidden dangers. The coroner's report would later suggest it was likely sudden cardiac death. Unspecified, but having cared for numerous cardiac patients, I couldn't accept that. He had no history of arrhythmia, no genetic predisposition, nothing posed an imminent threat. He knew. He simply knew. After the body was taken to the morgue, I sat alone in the staff lounge for a few minutes, still wearing my gloves. I kept reflecting on the expression in his eyes from the night prior. It wasn't fear, but peace, like someone who had made peace with the end before it arrived. In the ER, we strive to combat death. We shock it, intubate it, and medicate it into submission. But this man didn't resist. He approached it quietly and gracefully, as if it was just time to go. And perhaps that is what lingers with me the most. Not the death itself, but the certainty. They referred to it as the silent code. That's how we came to label it. Anyway, I have worked in the emergency department for over 20 years, long enough to recognize when a case is shifting, when someone is slipping away. But this one remains with me. It wasn't dramatic. No storms, no strobe lights, just the subtle ticking of monitors and the familiar chaos we are accustomed to. For over 17 years, I've worked night shifts in the emergency room, and the fast-paced environment and intense pressure have become second nature. You learn to block out the sounds that don't matter. The beeping machines, the groans from patients, and even the occasional arguments in the waiting area. But some things are impossible to ignore, like the footsteps. This would typically happen after 2 a.m., once the influx of trauma cases had decreased and only a skeleton crew was left. The lights were dimmed, the hallways were quiet, and the strong smell of antiseptic filled the air. I'd often find myself restocking the crash cart or making sure the portable suction unit was ready for emergencies when I would hear them. Footsteps. Not the faint noise of shuffling or a wheeled stretcher, but clear, purposeful pacing. Our ER has a long back hallway leading past the trauma bays and into radiology, and this corridor has always given off an odd feeling, especially at night. The footsteps would start near the trauma bay, 3 doors down from the main station. They moved slowly to the corridor's end, paused, and then turned around, repeating this back and forth, just pacing. I initially thought it might be a security guard wandering during quieter hours, but whenever I checked, there was no one there. Just the echo of footsteps that had already faded. The automatic doors to that hallway remained locked, and security footage revealed nothing unusual. I recall one night when I was keeping an eye on an elderly man with a GI bleed. He was on a dopamine drip, and his blood pressure was fluctuating dangerously low. The ECG was operational, and the room was quiet except for the sound of the 4-pump. Then, the footsteps returned just outside, steady and rhythmic. I instinctively checked the hallway empty. The distinctness of the sound quickened my heartbeat. I wanted to rationalize it. Maybe it was just an echo or a nurse on the other end, but those explanations didn't hold up. Other staff heard it too, including a newer nurse named Sam, a former military medic. One night, he caught me tending to an oxygen tank and asked if I had heard the footsteps. I hesitated but eventually realized we both recognized it wasn't just in our imaginations. Some nights felt routine, as if this unseen presence had a schedule, walking from one end of the hall to the other. There was nothing frantic or erratic about it, just consistent pacing, as if waiting for something or someone. Over the years, some nurses decided to leave the night shift, citing discomfort with the footsteps among other reasons. They claimed it brought back memories of patients we couldn't save, like a young girl we lost due to a hit and run. I vividly remember the attempts we made to save her during trauma. After that, the footsteps began. We never saw anything. No shadows or spirits, just the sound and an unsettling presence. It didn't feel malevolent, merely disconcerting and constant. I've witnessed enough death and loss in this job to accept that not everything can be explained. Some entities might linger because they're not ready to depart or because they feel a connection to this place. Some patients fight for life, while others may just continue their journey. So now, when I'm restocking the crash cart or adjusting equipment at 3:15 a.m. and I hear those slow, steady footsteps echoing down the corridor, I don't react as I used to. I simply listen and allow them to pass. Hello, everyone. Thanks for watching. A special thank you to our subscribers. You keep these chilling stories alive. However, only 30% of viewers are actually subscribed. If you appreciate our content, hitting the subscribe button really helps us out. Takes just a moment, but it makes a significant impact. Don't forget to like and share to keep the eerie tales coming. Thanks once more. You make this possible. Catch you in the next one if you dare. It was a Thursday afternoon, just after the lunch rush, and the ER had settled down enough for us to catch up on some charting. Suddenly, a code blue alarm sounded from bed 12. Without a second thought, we dropped everything and rushed over. The patient was a man in his mid-60s post-myocardial infarction, already in a fragile state. He had coded earlier that very morning but was revived following a brief series of compressions and 1 dose of epinephrine. By the time I arrived, he was intubated and monitored, but his vitals were unstable. We were losing him again. I distinctly remember the crash cart colliding with the side of the bed, making that familiar thud. I took my designated position, airway management. The respiratory therapist had already connected the bag valve mask to the wall's oxygen supply, and I focused on watching for chest rise while we manually ventilated him. The monitors were flatlining, but my team moved as if by instinct. We carried out compressions, established 4-access, placed the defibrillator pads, and drew and administered epinephrine. I called out each step as if I were following a script. 1 milligram of epinephrine administered. Continue compressions. Check for a pulse. Nothing. Still no output. Dr. Simmons was at the foot of the bed, observing the monitor. He's not the type to give up easily, but I noticed the heaviness in his expression. It had been over 20 minutes. We adhered to protocol. 5 rounds, no shockable rhythm. As Stolly suggested, let's give it another 2 minutes. His voice was low but resolute. One of the newer nurses glanced at me, her eyebrows raised, silently questioning, "Is this really worthwhile?" I kept ventilating. That's our job. We persist until the clock instructs us to stop. At the 22-minute mark, Simmons issued the verbal warning. If no rhythm is seen in 2 minutes, we will call it. That's when a shift occurred. It wasn't the monitor, which continued to show a flat line. It wasn't a beep or a sudden spike in rhythm. It was his eyes. They opened slightly at first, but I recognized it. I knew what I saw. No one else noticed until I paused ventilating. Then he gasped. A deep, ragged, unmistakable breath. It wasn't agonal. It was genuine, intentional. We froze. Simmons leaned closer, assessing his pupils. "Get me vitals," he commanded. The tech was already inflating the blood pressure cuff again and reattaching the pulse oximeter. The cardiac monitor began to show faint electrical activity. Sinus bradycardia at 38 beats per minute, but it was there. He had returned. Then he whispered. I was leaned in, listening for any airway sounds when I heard him say it. Almost inaudible, his lips dry, voice raspy from the tube and the ordeal. I was already gone. That was all. I can't convey how cold the room became. Not in temperature, but in atmosphere. It was a stillness that conveyed we had all heard the same thing, and none of us knew how to process it. We stabilized him. Oxygen saturation gradually improved. Blood pressure remained weak, but we sedated and monitored him. Later, he was transferred to the ICU, intubated and unresponsive, yet alive. That whisper lingered in the air for hours. I was already gone. I documented every detail with precision. Time of last compressions, time of return of spontaneous circulation, ROSC, medications given, Glasgow Coma Scale, pre- and post-code. It has become second nature by now, yet that night I spent more time at the keyboard than usual. We don't discuss it often. It wasn't a horror show. It was simply strange, quiet, profound, and real. The patient eventually stabilized and was extubated a week later. I visited him prior to his discharge. He didn't recall much, just fragments. He mentioned a sensation of being weightless, followed by awakening to my face hovering over him. He never referred to the whisper. Perhaps he was unaware he had said it, or maybe he was. For me, that code transformed something within. Not dramatically, not like in the movies, just a quiet realization that occasionally, we find ourselves on the brink of something we don't fully grasp. That's why I continue to show up. Every shift, every code, because sometimes, even when it appears to be finished, it is not. Good evening. My name is Marcus. I work as an EMT with the local emergency services, and what I'm about to share happened one night in September. This experience made me question everything I thought I understood. After you hear my story, I believe your perception of reality might change as well. I've always been a skeptic. In my line of work, I encounter life and death situations daily, and I thought I had seen it all. However, an event that took place in September 2005 challenged my beliefs. I was on duty with my partner, Jessica. Before I dive into the story, you need to know something about her. Jessica is known for her honesty and straightforwardness. She's not one to tell tall tales or exaggerate her experiences. If she claims to have seen something, you can trust it happened. Now, let me continue. It was around 11 p.m. when we received a call to assist a patient in cardiac arrest in the Maplewood area of Oak Ridge. The adrenaline was pumping as we sped towards the location, sirens blaring and breaking the quiet of the night. Upon arrival, a family member was waiting for us at the entrance, anxiety visible on his face. Jessica entered first, and I followed closely behind with our equipment. That's when I noticed something unusual. Jessica appeared to be speaking to herself, her lips moving as if conversing with someone invisible. When we reached the living room, we discovered the patient on the floor, showing no signs of life. We immediately began resuscitation efforts. I concentrated on our standard procedures: chest compressions, defibrillator, adrenaline, when something caught my attention that left me perplexed. Jessica was addressing the patient by his name. "Come on, Mr. Johnson. Stay with us." How did she know his name? We hadn't been provided any information about him other than the address and that he was in respiratory distress. The family hadn't mentioned his name at all. Despite our best efforts, we couldn't bring him back. Mr. Johnson had passed away. It's heartbreaking to lose a patient, but it's part of our reality. On the way back to the ambulance, my curiosity got the better of me. I asked Jessica how she knew the patient's name. Her response left me astonished, delivered with a gravity that was impossible to ignore. Jessica looked me in the eyes and said, "Marcus, I saw Mr. Johnson's spirit. He was sitting calmly on the couch, watching everything we were doing." I was at a loss for words. Jessica continued. "He spoke to me, saying that trying to save him was futile, that his time had truly come. If anyone else had shared such a story, I would have dismissed it as stress-induced imagination. Yet, Jessica had never been one for fantastical stories or exaggeration. The conviction in her voice and eyes left no room for doubt. In the following days, I couldn't shake off what had occurred. No matter how hard I tried to rationalize it, I found no explanation. I began to recall other unusual instances involving Jessica. One time, after we responded to a traffic accident, she went straight to a particular spot on the roadside, far from the actual scene, and found a child who had been thrown from the vehicle. No one else had noticed the child there. How did Jessica know exactly where to search? Then there was another occasion when we were called to a workplace incident downtown. For reasons unbeknownst to me, Jessica suggested taking the stairs instead of the elevator because it would be quicker. Minutes later, the entire block experienced a power outage. If we had been in the elevator, we would surely have been trapped. After that night with Mr. Johnson, I began to observe Jessica more closely. The more I watched her, the more I sensed that she possessed an unusual intuition, something beyond the normal five senses. One day, I finally gathered the courage to ask her about these seemingly supernatural abilities. She looked uneasy but eventually shared her thoughts. Jessica revealed that she had seen and heard things that others couldn't since she was a child. Initially, she believed she was losing her mind, but over time, she learned to accept this sensitivity and even use it to assist others. "It's like I have one foot in each realm," she explained. "Sometimes it's a burden to see those who have passed on or to hear voices that no one else can, but I've learned to make use of this gift in our work." Her honesty prompted deep reflection within me. In our profession, we navigate the thin line between life and death every day. But what if there's more happening than what meets the eye? What if death isn't the end, as I once thought, but rather a transition to another form of existence? After that conversation, I began to notice other unexplainable events during our shifts. Sometimes Jessica seemed to know exactly what had occurred at a call location before we even arrived, or she'd make astonishingly accurate diagnoses of complex cases without conducting detailed tests. There was an incident where we assisted a couple involved in a traffic accident. The driver was unconscious and critically injured, while his wife, Mary, had only minor scratches. To my surprise, Jessica began addressing the unconscious man as if he could hear her. "Calm down, Mr. Johnson. We're here for you. Your wife, Mary, is fine. Don't worry." The most fascinating part was that when the man regained consciousness at the hospital, his first question was, "Where's the woman who spoke to me in the car?" Over time, I began to experience sensations that I couldn't explain. While not as intense as Jessica's experiences, they were definitely real. Sometimes, as I entered a location, I'd feel a heavy, oppressive atmosphere. Other times, I'd have the strong impression of being watched by something otherworldly. One night, we were returning from a call around 3 a.m. when the road was nearly deserted. Suddenly, I felt an intense chill, and Jessica instructed me to pull over onto the shoulder. Without hesitation, I did so. Seconds later, a runaway truck zipped past in the exact lane where we would have been if we hadn't stopped. That experience fundamentally altered my perspective. Although I still believe in science, medicine, and the protocols I was taught, I now understand that there are things beyond scientific explanation. These days, when Jessica makes an unusual comment during a call, I no longer question her judgment. If she suggests a different approach, we trust her intuition. Interestingly, our success rate in helping patients has significantly improved since I began to trust her insights. Sometimes I think that we all might have a hint of that sensitivity, but perhaps we haven't developed it fully. Maybe it just takes a bit of attention to the subtle signs around us. What I know for certain is that after that night with Mr. Johnson, I changed forever. Now, during every call, I'm aware not only of vital signs and visible symptoms, but also of the subtleties I once overlooked, like shifts in the atmosphere of certain locations or the feeling of a presence, even when no one is visibly there. Remarkably, this has made me a better EMT. I've come to realize that caring for people extends beyond the physical realm. Sometimes offering spiritual support or saying the right words at the right moment can be transformative. So, the next time you feel an odd chill or sense that something more is afoot around you, don't dismiss it. Perhaps you too have a unique sensitivity waiting to be discovered. If my story has prompted you to reflect on some unexplainable experiences of your own, it might be that our perception is wider than we think. Thank you for listening to my account. Good evening, everyone. I'm Alex, and tonight I'd like to share a story that may change your perspective on the existence of ghosts. This experience took place in the late 1980s while I was working at Maplewood Medical Center. What I encountered back then made me realize that some locations hold the echoes of the past in ways we can't fully explain. To be honest, before I started my job at Maplewood, I was one of those skeptics who found ghost stories amusing, believing they were just figments of imagination. That changed drastically due to my time at the facility. It was 1985 when I had just completed my nursing degree and secured a position at the hospital. I was thrilled, feeling like I was destined to make a significant impact. However, I had no idea that the true transformation would happen within my own mindset. Maplewood Medical Center was far from ordinary. Established in the 1800s, it had witnessed a great deal over the years. During a local war from 1845 to 1848, the hospital overflowed with injured soldiers. You can picture the chaos. Halls filled with men in agony, frantic doctors hustling everywhere, with a palpable scent of blood lingering in the air. From my first day on the job, I heard the veterans speak of unusual happenings. They recounted tales of voices echoing in the dead of night, footsteps resonating in empty corridors, and even sightings of soldiers clad in old-fashioned uniforms. Initially, I dismissed these stories, thinking the staff just needed a break. The first night on my shift was uneventful enough. Sure, there was the usual heavy atmosphere of a hospital after hours, but nothing frightening. However, by my second week, things started to get strange. As I was making my rounds one night, I heard a sound coming from one of the rooms. Thinking it was a patient seeking assistance, I went to investigate. When I opened the door, I was taken aback. A man in a vintage military uniform stood at the foot of the bed, saluted me, and then disappeared right before my eyes. I quickly shut the door and opened it again, but there was no one there, just the patient peacefully asleep. I won't lie, it unnerved me. Yet, I reassured myself that I was just overtired. After all, it was around 3 a.m., and I was deep into a long shift. Surely, my mind was playing tricks, right? But then, similar occurrences kept happening. Other nurses, doctors, and patients started reporting odd events. One nurse insisted she heard military commands being shouted in an empty hallway. A doctor claimed to have witnessed a group of wounded soldiers walk straight through a wall. The night that left the most profound impact on me was when we admitted a distressed patient who wouldn't stop shrieking for us to remove a soldier from his room. We checked repeatedly but found nothing, as the room appeared empty to us. Yet the patient insisted there was a young cadet there, simply watching him in silence. Can you imagine his fear? When morning arrived and he was discharged, I had never seen someone so relieved to leave. After that incident, I began to pay close attention to my surroundings. I noticed the air growing colder in certain hallways, the eerie sounds emanating from the aging building, and shadows that seemed to flit by on their own. However, the event that truly convinced me something supernatural was at play occurred a few months later. We admitted a seemingly healthy young soldier. As a precaution, the on-call doctor decided he should stay overnight for monitoring. It was not a serious case, or so we believed. In the dead of night, the cardiac monitor began beeping wildly. We rushed to his room and found the soldier in cardiac arrest. Despite our efforts, we could not revive him, leaving the entire team in shock. How could a healthy young man pass away so suddenly? The following night, as I made my rounds, I witnessed something that made me question my sanity. At the end of the hallway, near a window, stood the same young man who had died the previous night. He looked at me with sorrowful eyes before vanishing into thin air. I stood there, trying to grasp what had just transpired. Was I imagining things? Was my exhaustion causing me to hallucinate? But I wasn't alone. Over the next few nights, several colleagues reported seeing the same soldier in various parts of the hospital, the chapel, near the emergency exit, always bearing that same mournful expression, as if he were forever lost. These occurrences persisted for many months. At times, it was merely a fleeting silhouette, but on other occasions, it felt as though he were truly present, almost tangible. On certain nights, the air would grow frigid, alerting us to the presence of something supernatural. Eventually, these sightings became scarcer until they ceased altogether. However, the hospital was forever altered in my mind thereafter. It felt as if the walls held untold secrets, and every nook concealed a narrative we couldn't fully grasp. Strange stories circulated, too. Patients spoke of voices echoing in the dead of night, shadows darting through hallways, and doors mysteriously slamming shut. There was an instance when a new nurse sprinted out of the supply closet, pale and shaken. She claimed to have seen a group of injured soldiers sitting on the floor as if awaiting care. Another time, while I was alone in the staff lounge, I heard an unsettling sound that froze me with fear. It was a low noise, nearly imperceptible, yet I recognized it as the rhythm of military boots, like marching. I stepped into the hallway, anticipating to find someone with a radio, but no one was there. The sound amplified, as if an entire regiment were marching toward the hospital. I could hear footsteps, the clatter of gear, and even distant voices issuing commands. It felt like the past had resurfaced, bringing back all the soldiers who once occupied those grounds over a century ago. I stood paralyzed as the noise escalated and then gradually diminished, as though the Phantom Battalion had moved right past me. When quiet returned, I had the eerie sensation of having witnessed something surreal, an echo of a bygone era trapped within those walls. Following that night, my awareness heightened. I noticed how the lights occasionally flickered for no apparent reason, the sudden scent of blood wafting through certain hallways, or faint groans emanating from empty rooms. Once, while assisting in transferring a patient, the individual became distressed and pointed down the corridor, insisting that a group of wounded soldiers was there. To our eyes, the space appeared vacant. Yet in his vision, the hall was crowded with bloodied men, some missing limbs, pleading for help. Strangely, over time, you adapt to these experiences. They remain unsettling, but they eventually weave into the fabric of daily life. You learn not to flinch when you hear footsteps trailing behind you in an empty corridor or feel a hand on your shoulder, only to turn and find no one. Years passed as I continued my work at the hospital. The bizarre happenings never truly vanished. They ebbed and flowed. I noted that during the anniversary of that mid-century battle, the activity heightened. It was almost as if the date revived the memories ingrained in the building. I became intrigued by how some patients seemed extra attuned to these events. Some could spend weeks in the hospital without noticing anything strange, while others would arrive and, on their very first night, start experiencing unsettling phenomena. I often wondered if certain individuals were simply more receptive to the supernatural or if the spirits chose their communicators. Over time, I grew to respect these presences. It transitioned from fear to acceptance, recognizing there are aspects of existence beyond our understanding. On quiet nights while working alone, I found myself addressing them. "Good evening, everyone." I would whisper to the empty hallways, and there were moments I felt a response, as faint as it might have been. Years after leaving the hospital, those experiences remain vivid in my mind. In many ways, they reshaped my perspective on life. I often ponder those spirits. Are they still in that hospital, trapped in some way? Will they ever find resolution? Or are they fated to endlessly replay their final moments? Maplewood Medical Center still stands, its presence as formidable as ever, safeguarding its mysteries. I am convinced that even now, while you absorb my tale, something inexplicable is at play in those aged corridors. From everything I encountered, one truth became clear. Reality encompasses far more than we often grasp. There are elements of existence science may never elucidate, and that's perfectly fine. Sometimes the enigma itself is what renders life beautiful. So, if you ever find yourself in an old building, a hospital in particular, take heed. Peer into the shadows. Listen closely to the stillness. You might just catch a glimpse of something extraordinary. And if you do, don't be afraid. As I learned in that hospital, not all spirits are there to frighten us. Some simply wish to be remembered. I'm sure many individuals across the country have experienced similar events in hospitals. Why not share your stories, too? Certain hospitals conceal secrets that transcend the limits of science. There are locations where the divide between life and death is more fragile than one might think. My name is Sarah, and I worked as a nursing aide at Riverside Medical Center in Green Valley. What I'm about to reveal took place during my night shifts in the burn unit. People often mention that hospitals hold myriad tales, but nothing could have prepared me for the occurrences I witnessed there. My first night at the hospital is permanently etched in my memory as the onset of a nightmare. The heavy silence of the hallways was pierced only by the incessant beeping of heart monitors and the occasional groans of patients. The sharp scent of antiseptic never fully concealed the lingering odor of singed flesh. It was during the midnight rounds that I sensed something unusual. Upon entering one of the rooms to check on a patient, I felt an intense chill that had no explanation. The air conditioning was turned off, yet my breath formed tiny clouds of vapor. The patient, a middle-aged man with extensive burns, lay motionless, his gaze fixed on a shadowy corner of the room. I approached cautiously, softly calling his name. He didn't respond, continuing to stare into the void. When I touched his arm to check his vital signs, he suddenly turned his head, his eyes wide with fear. "She's here," he murmured in a raspy, trembling voice. "The girl. She won't stop watching me." He pointed toward a corner, but all I noticed was an empty chair beside the window. I tried to reassure him, thinking it was a side effect of the pain medication. However, as I turned to leave, I caught a glimpse in the window's reflection. A small figure sitting in the chair. It vanished the instant I blinked. In the weeks that followed, similar occurrences became alarmingly common. Various patients at different times all reported seeing the same figure. A girl in white, quietly seated in that chair. Some described her as comforting, while others were filled with dread at her presence. One night, a senior nurse confided in me, her eyes wide with fear, about the history of that room. Years ago, a young girl had perished there after suffering severe burns while trying to rescue her brother from a fire. Ever since, her spirit had lingered in the area. The case that impacted me the most occurred 3 months later. A patient in critical condition, with burns covering 80% of his body, was under our care. His condition deteriorated rapidly, and we knew it was only a matter of time. During my early morning shift, I entered his room to change his four. The cold that enveloped me was piercing, causing my teeth to chatter. The patient was awake, his eyes fixated on that infamous chair. But this time I could see it too. Sitting there was a girl, no older than 12, with long dark hair and a white dress stained with ashen blood. Her skin bore horrific burns, partially healed. She was gazing at the patient with an expression of profound sadness. I froze in place, unable to move or scream. The girl slowly turned her head in my direction, her eyes meeting mine. There was no malice in them, only deep sorrow and something else, an expectation. Suddenly, the monitors began to beep frantically. The patient was going into cardiac arrest. I snapped out of my trance and ran to call the emergency team, but by the time we returned to the room, it was too late. The most disturbing detail was what we found on his body. Small handprints covering his burned skin, as though someone had tried to pull him out of the bed. And on the chair, now empty, there were ashes scattered across the seat. In the months that followed, the activity in that room intensified. Objects moved on their own. The temperature would inexplicably drop at times, and occasionally, the air was filled with the scent of smoke despite there being no fire. Patients described vivid dreams where a burned girl called out to them, urging them to follow her. Some woke up with strange light burn marks, while others asserted they had seen the girl hovering above their beds at night. The staff started to steer clear of that room. No one wanted to be alone there, particularly in the early morning hours, as whispers of a malevolent force feeding off the anguish of burn victims circulated throughout the hospital. I tried to cling to my sanity to make sense of the occurrences, but each shift brought new terrors. One night, while checking on a sedated patient, I heard a child's voice singing a lullaby. Turning slowly, I saw the girl perched on the edge of the bed, gently caressing the face of the unconscious patient. When she noticed me, she smiled, but it wasn't a reassuring smile. It was something predatory. Her lips moved, forming words I couldn't hear yet somehow understood. "You're next." I fled the room, my heart racing wildly. That same night, I submitted my resignation. I could no longer endure that presence, the constant fear, the sensation of being observed by something that no longer belonged to this realm. After leaving the hospital, I started experiencing dreadful nightmares. They recurrently featured me racing desperately through endless hallways, with a girl in a white dress chasing me, her hands reaching out as if she wanted to touch me. Years passed, and I still couldn't enter a hospital without feeling a chill run down my spine. The experiences at Jackson Memorial haunted me so profoundly that I chose to leave nursing entirely. I simply could not endure the hospital atmosphere any longer. Every corridor reminded me of that terrifying entity. In search of a fresh start, I obtained a degree in aesthetics and began working at a private clinic. The clean, quiet environment there offered a comforting contrast to the horrors I had experienced at the hospital. However, even that significant change of scenery did not entirely banish the shadows of my past. Away from the hospital, there were moments when gazing at mirrors or reflective surfaces, I felt the terrifying sensation of catching a glimpse of a burned girl staring back at me. These visions occurred often enough to make me question my own sanity. Seeking peace, I reached out to a local spiritualist center. The medium who received me listened gravely to my story. He explained that sometimes traumatic events could open pathways to the spiritual realm, allowing certain entities to attach to us. I dedicated months to attending spirit release and cleansing sessions. The process was intense and often frightening. During one particularly intense session, the medium entered a trance and spoke with the voice of a child. The message was confusing, mixing pleas for help with dark threats. Gradually, the visions began to diminish. The reflections in mirrors became less frequent, and the sudden chills almost vanished. Yet the fear lingered. Even after my time at the spiritualist center, the true nature of that entity remained unclear to me. Was it genuinely the spirit of a young girl trying to comfort other sufferers, or something more sinister using the facade of an innocent child to approach vulnerable souls? Whatever it was, it left marks on everyone who came into contact with it. A dark reminder that some things in this world defy our understanding. Sometimes what may seem like a guardian angel could actually signify something much darker. To this day, years later, I still awaken in the middle of the night, drenched in sweat, convinced that I can feel those small, burned hands touching my face and hear that childlike whisper echoing in my ears. At times, I wonder if I will ever completely escape that young figure, even with regular visits to the spiritualist center. My new life at the aesthetics clinic is peaceful and satisfying. However, I can never erase what I went through. The emotional scars remain, alongside a lingering uncertainty about the true nature of those events, both inside and outside that hospital. If you work or have ever worked in healthcare, perhaps you have your own mysterious story to tell. Sometimes sharing these experiences helps us realize there are more enigmas lurking in hospital corridors than we could ever imagine. My name is Ethan, and for many years, I worked as a surgical instrument technician at the Metropolitan Medical Center in New York City. What I'm about to recount took place in the early 2000s in an operating room that became the center of bewildering occurrences. Get ready for a dive into the eerie side of medicine, where the boundaries between life and death blur, and the mysterious challenges everything we once thought we understood. The scent of antiseptic lingered in the air as I walked through the chilly halls of the surgical unit. It felt like just another regular day at the medical center. At least that's what I thought. It all began on an ordinary Tuesday. As I was organizing the tools for a standard surgery, the lights in the operating room began to flicker. Initially, I didn't think much of it. Old hospitals have their quirks, I reasoned. But then the cardiac monitor started beeping inexplicably, even though it wasn't attached to any patient. We called in the maintenance crew, and they scoured the room, checking every wire and outlet, yet found absolutely nothing to explain the strange occurrences. The technician shook his head, mumbling something about electromagnetic issues, yet his eyes conveyed he was just as puzzled as we were. In the following weeks, bizarre incidents multiplied. Surgical tools would inexplicably relocate, temperatures would sharply fluctuate, and the unthinkable occurred. During a gallbladder removal, a routine procedure we performed almost daily, the patient, previously healthy and with no anticipated complications, suddenly crashed. Within minutes, we lost him with no medical explanation for the tragedy. The surgical team was shaken, and whispers filled the hallways. accompanied by suspicious glances towards that operating room. However, the daily grind of hospital life continued. A week later came another unsettling event. A patient unexpectedly regained consciousness during the procedure, something extremely rare nowadays. Before we could respond, he started uttering unintelligible words. His voice was deep, hoarse, and oddly unnatural. Moments later, he went into cardiac arrest. That was the moment fear truly started to spread. Nurses began refusing to enter the room alone, and even the most skeptical surgeons hesitated before making a single incision. I, too, began to feel an unsettling presence every time I crossed that threshold, as if something unseen was watching us. The flickering lights intensified. There were times we were plunged into complete darkness for what felt like an eternity. During those blackouts, some staff claimed they heard whispers and the dragging of footsteps on the floor. The situation escalated with yet another unexplainable death occurring within a month. This time, the lights didn't just flicker. They burst in a dazzling display of sparks. The air turned icy, so cold we could see our breath. I could have sworn I glimpsed a dark figure lurking in the corner of the room, observing us with eyes that glowed in a bizarre hue. Hospital management could no longer overlook the phenomenon. There were closed-door meetings and intense discussions, with rumors circulating that they even considered permanently shutting down the operating room. That was when someone suggested a unique solution, a blessing. The idea of bringing a priest into such a clinical environment sparked debate, yet desperation won out. On the agreed day, the priest arrived. He was an elderly man with eyes that seemed to carry countless secrets. As he conducted the ritual, the air thickened, making it hard to breathe. The lights flickered wildly, and for a fleeting moment, I thought I heard a distant scream, as if something was being forcibly removed from that room. When the ceremony concluded, a profound silence enveloped us. The priest surveyed the room, nodded solemnly, and departed without saying a word. We stood there, uncertain of what to anticipate. In the weeks that followed, noticeable changes occurred. The lights ceased their flickering, the equipment functioned flawlessly, and no further unexplained deaths transpired. It felt as if a weight had been lifted from that room. However, my relief was tinged with an odd sense that lingered. Sometimes, when I found myself alone in the operating room, I could still feel something present. Observing, waiting. It wasn't a hostile presence, but one that seemed watchful. To this day, we never truly uncovered what transpired in that room. Some argue it was merely a string of coincidences intensified by stress and imagination. Others are convinced that something genuinely supernatural was at play. As for me, I began to perceive the world differently after those incidents. I came to understand that there are phenomena between heaven and earth that science has yet to comprehend, and that the divide between life and death is often much thinner than we care to acknowledge. Now, years later, I still work at the same hospital. The operating room remains in use with no further occurrences. Yet, every time I enter, I can't shake that feeling of being watched. Good evening. Have you ever considered whether what we perceive is truly all that exists? I'm Lily, and a few years ago, I worked as a nursing assistant at a senior living facility in Springfield, Ohio. What I'm about to recount happened to me during a night shift there, and it profoundly altered my understanding of reality versus the supernatural. You know that uneasy feeling you get when something just feels off, even if everything seems fine? That's how I felt one night in 2019 while working my shift at the facility in Springfield. Normally, I was a person who relied only on what was visible and tangible. After all, in the healthcare field, one learns to trust science and facts. But let me tell you what transpired that night, which shook my beliefs to their core. The shift began like any other long night. I arrived around 7 p.m., received handover from the day staff, and prepared for a quiet evening tending to our elderly residents. The facility was a cozy place, with comfortable rooms and a spacious common area. The nursing station was set up in a curved glass enclosure, allowing me to observe nearly half of the resident rooms. I felt a bit anxious this time as it was my first night shift alone. Normally, there would be another nurse with me, but my partner was absent due to personal issues. Around 11 p.m., things took a strange turn. I was busy jotting down notes in a residence chart when I heard the first odd sound: footsteps. However, these were not typical footsteps. They were slow and dragged, as if someone was struggling to walk. I looked up, expecting to see a resident needing assistance, but the space was deserted, shadows dancing in the low light. Deciding to investigate, I conducted a round, checking on each resident. Everyone was soundly asleep in their beds. No one appeared to have gotten up. Returning to the nursing station, I attempted to brush off the noise as a figment of my imagination. But then it happened again. This time, it wasn't just footsteps. I heard a creaking sound as if a door was being opened slowly. My heart started to race. I scanned the room through the glass of the station, but saw no sign of life. No movement, no indication that anyone was awake. I conducted a more thorough round, checking all the bedrooms, bathrooms, the kitchen, and even the supply closets. But everything was in order, and residents remained peacefully asleep. When I got back to the station, I was genuinely starting to feel frightened. The strange sounds continued: footsteps, creaking, and now faint music, a ghostly children's tune as if echoing from a distance. I grabbed my phone and called my brother overseas. I just needed to hear a familiar voice to ease my nerves. As I explained the bizarre noises happening around me, I felt tears welling up. It all seemed like something out of a horror movie. And then it happened. While I was talking to my brother, I glanced to my left and saw something that made me freeze in terror. One of the residents was standing outside the glass enclosure, staring at me with an expression of rage I had never seen before. She raised her hand and pounded on the glass, the sound reverberating through the silence. I quickly hung up and rushed to assist her, my heart pounding in my ears. This resident had suffered a stroke a few years back and typically appeared calm and confused. But that night, she seemed completely transformed. Her eyes were wide, fixated on me with a frightening intensity. I tried to talk to her, asking what she needed, but all I got in response were angry murmurs, unintelligible words that spilled from her lips like curses. The more I attempted to soothe her, the more agitated she became. Eventually, I managed to guide her back to her room and gave her medication early since it was almost time for her dose. As I helped her settle down, I noticed her body was icy cold, as if she had been outside in the winter for hours. The moment she lay down, she went still, her eyes closing and her breathing calming instantly, as if a switch had been flipped. My hands were trembling as I returned to the nursing station, and suddenly, everything was quiet again. The facility was silent, as if nothing had occurred. The rest of the night passed with me on high alert, waiting for something else to happen, but nothing did. By dawn, when the next shift arrived, I was utterly drained and bewildered. I shared my experience with the incoming nurse. She listened, but I could see skepticism in her eyes. She suggested that perhaps fatigue was affecting me and that night shifts could take a toll. But I knew what I had witnessed and heard. It wasn't exhaustion or stress. It was something unexplainable, something else entirely. 2 days later, I received news that left me even more perplexed. The resident who appeared that night had passed away. Another stroke, more severe than the first, occurred. I pondered whether she sensed that her time was limited. I questioned if that nighttime appearance and her inexplicable anger were warnings or cries for help that she couldn't articulate in any other way. In the days that followed, I found myself unable to stop contemplating what transpired. I began to pay closer attention to the stories shared by a coworker who claimed to practice voodoo. She frequently spoke of spirits residing in the retirement home, entities that sometimes manifested. I had previously dismissed these tales as mere superstition, but following my experience, I couldn't ignore them any longer. What if there was something beyond our comprehension? I started noticing small details that I had overlooked before. For instance, how the lights would sometimes flicker without explanation. How motion detectors around the building would activate even when no one was nearby. How the air in certain hallways would occasionally turn inexplicably chilly. After speaking with other coworkers, I found out I wasn't the only one to have encountered strange occurrences. One nurse shared that she had once witnessed a child running down the hall, but when she went to investigate, no one was there. No children at all present in the building. A caregiver insisted he sometimes heard voices emanating from vacant rooms. These accounts made me reassess everything I believed. As a healthcare professional, I had been trained to seek logical explanations and trust what could be substantiated. However, how could I rationalize what I experienced that night? I began to approach my work from a different angle. I started to pay closer attention not only to the physical indicators in the residents but also to their behavior and what they said, even when it seemed illogical. I came to realize that many residents, particularly those close to death, sometimes talked about seeing individuals who weren't there. Deceased relatives, childhood friends, people they hadn't encountered in many years. Previously, I attributed these visions to confusion stemming from advanced age. Now, I contemplated whether there was something deeper at play. That night's event altered not just my professional viewpoint, but also my personal perspective on life and death. I began to wonder if the boundary between these two states is as clear as we believe. Perhaps at certain moments, that boundary becomes blurred, enabling us to perceive or sense things typically beyond our awareness. I have not ceased being a committed, evidence-based professional. I continue to perform my responsibilities diligently and adhere strictly to medical protocols. However, there is now an added layer of understanding, a willingness to consider possibilities I would have previously dismissed. I started to be more attentive when residents shared their stories, fears, and visions. I understood that often what they needed wasn't merely physical care, but someone who would listen without judgment, who would affirm their experiences, no matter how peculiar. The retirement home stayed a place of care and comfort for the elderly. But for me, it transformed into a realm of intrigue and continuous learning. Each night shift held the potential for new revelations, experiences that tested my understanding of reality. Even today, years after that unsettling night, I lack definitive answers. I cannot assert with certainty whether what I encountered was genuinely supernatural, an unexplainable phenomenon, or merely a series of odd coincidences. What I can assert is that the experience made me more open-minded and more empathetic. I discovered that there are more enigmas in this world than we can explain. Sometimes, the most crucial thing we can do is to simply be present, to listen, and to provide comfort. No matter the nature of our challenges, whenever I pass by a retirement home or any historical place filled with lived experiences, I can't help but wonder what those walls conceal beyond what is visible. What stories, what energies, what presences might exist there, invisible to our sight, yet perceptible to our other senses. Have you ever encountered an event you couldn't rationalize? Something that tested your understanding of reality? Perhaps like me, you'll discover that there is more to existence than what our eyes perceive or our minds can fathom. Which story resonated with you the most? Share your thoughts in the comments. Don't forget to subscribe, like, and share. I'll see you in the next story if you're brave enough.